Доброго вечора, українські радіаційні онкологи, медичні фізики, радіаційні терапевтичні технологи. Слава Україні! Дуже дякуємо, що приєдналися до Modern Brachytherapy course with ABS experts for Ukraine. Help Ukraine Group in collaboration with American Brachytherapy Society with Care Support is excited to present the 7th lecture in this course. The topic of today's lecture is very broad, GYN HDR brachytherapy, and we have two fantastic speakers for this lecture. Dr. Elizabeth Kidd is a professor at Radiation Oncology Department at Stanford University. Dr. Kidd earned her medical degree from Washington University School of Medicine in 2005 and completed her radiation oncology residency here, or also there in from Washington University School of Medicine in 2010. As a radiation oncologist at Stanford, she specializes in the treatment of GYN cancers with a clinical and research focus on brachytherapy for cervical, endometrial, vaginal malignancies. Her work aims to optimize and individualize treatment to improve disease control, reduce side effects, and enhance patient quality of life. She's particularly committed to advancing procedural efficiency, refining treatment planning, broadening access to high-quality brachytherapy. For her achievements in advancing the field, she became a fellow of ASTRA this year. Congratulations, Dr. Kidd. And our second speaker is very dear to my heart, Dr. Thomas Niedermayr. He is a clinical professor in the Department of Radiation Oncology, Medical Physics Division, Stanford University. He serves as the section chief of brachytherapy physics. He earned his PhD in physics from Pierre and Marie Curie University in Paris, France in 2002, and completed his medical physics residency at Mayo Clinic in 2010. Before transitioning into clinical medical physics, Dr. Niedermayr conducted research in radiation detection at Berkeley National Lab and Lawrence Livermore National Lab. Prior to joining Stanford, he worked at Harvard as a clinical medical physicist at Brigham and Women's Hospital. He is an amazing educator, receiving numerous teaching awards from ARO, from Harvard and Stanford. Both Drs. Kidd and Niedermayr wrote numerous publications on GYN brachytherapy and are authors of the recent ABS guidelines for hybrid intracavitary interstitial brachytherapy for locally advanced cervical cancer. Thank you so much, both of you, for preparing the lecture today. It's an honor for the Ukrainian community to have you teach us. We are looking forward to your lecture on GYN brachytherapy. I will stop sharing.
Thank you, and then I'll share my slide. Thank you for the opportunity to present. So, as Natalia said, we'll be talking about brachytherapy for GYN cancers, which is somewhat broad topic. So from this talk, you'll become familiar with cervical cancer brachytherapy treatment approaches, the target volumes used for brachytherapy, and dose recommendations. You'll also learn the indications and common dosing for vaginal cylinder brachytherapy. And then you'll also understand the brachytherapy target volumes for primary vaginal cancer or recurrent endometrial cancer isolated to the vagina. So just to give a little overview, we'll start off with talking about intact cervix cancer brachytherapy, then vaginal cylinder brachytherapy, and then interstitial brachytherapy. And then Dr. Niedermayr will cover GYN brachytherapy planning and 3D printing. So just to start off with a little bit of background about why we use brachytherapy. So generally the treatment of locally advanced cervix cancer will be the combination of external beam radiation, generally with concurrent chemotherapy, and also the inclusion of brachytherapy. And the reason we do this is it allows us to add in more dose to the area of the tumor and improve disease control. So we have data from MD Anderson, that's older data, that showed that with a lower dose of external beam, meaning a higher dose of brachytherapy, there was improved disease-specific survival and lower grade 3 to 5 complications or toxicity. Additionally, we have database data that has shown a decreasing use of brachytherapy with a corresponding increasing use of SBRT and IMRT, which unfortunately showed significantly worse survival for patients who were treated with SBRT or IMRT as opposed to brachytherapy. This detriment was more substantial than not having concurrent chemotherapy. So brachytherapy is really an essential part of curative treatment for cervix cancer. And there's really been a lot of advances in the treatment of brachytherapy and how it's performed. Early on with brachytherapy, there was mostly just 2D imaging where we could see the applicators, and then we would use surrogate points for the bladder and rectum to approximate the dose to those normal tissues. But with advances in 3D imaging, in particular with MRI, we can now see the cervix tumor, and we can also better see the normal tissues for optimizing the dose both to the tumor and minimizing the dose to the adjacent normal tissues. And using this approach with MRI, or image-guided adaptive brachytherapy, was really pioneered by the GEC Estro group. In the early 2000s, that group decided it was important to support and promote 3D imaging-based treatment planning for cervix cancer brachytherapy. And they thought that from that goal, it was important that everyone was using a common language for how we defined the target volumes to promote research and develop an optimized approach towards image-guided adaptive brachytherapy. So in terms of the terms that they defined, they talked about GTV, or the gross tumor volume, which is defined both based on clinical exam and T2 MRI, both at the time of diagnosis and at the time of brachytherapy. They also defined what we call the intermediate risk CTV, which is approximately the size, the dose, or the extent of the tumor at diagnosis, and put forth the recommendation that that region or volume should get approximately 60 gray from the combination of external beam and brachytherapy in EQD2 calculation. And then they also define the high-risk CTV, which encompasses the entire GTV and cervix at the time of brachytherapy, and have the recommendation that that region or volume should get 85 to 90 gray from the combination of external beam and brachytherapy. They also put forth recommendations about the dose to normals, and they talked about the max dose to different volumes, the 0.1, 1, and 2 cc to the rectum, sigmoid, and bladder. And they found that the 2 cc was kind of the best for tracking because it was reproducible across fractions. And interestingly, the rectum 2 cc max dose region actually corresponded to the historical ICRU rectal point, as shown with the star, whereas the 2 cc max dose to the bladder was actually in a distinct region than the ICRU bladder point. So they put forth these recommendations about target volume contouring and dose to these structures or regions, as well as dose limits to these normal tissues. And so then they were following those. And with that approach, they initially presented on the retro-embrace data and showed that following this approach of image-guided adaptive brachytherapy significantly decreased local recurrence. So following this approach changed disease outcomes. And then they also had their prospective Embrace 1 study, which was across multiple institutions, that was published a few years ago, which showed very favorable survival and excellent local control for all stages, around 90%, and then also very favorable low toxicity by following this approach. And they also learned a lot from their recommendations about target volume coverage and dose limits, because the previous recommendations had been based on expert opinion, and now they had the prospective data to evaluate, how the dose translated into treatment outcomes and toxicity. And so for Embrace 2, they further refined their dose recommendations, so that essentially what they were originally recommending in Embrace 1 were the hard constraints or limits, both in terms of target coverage. So originally they were recommending, for example, the high-risk CTV D90 be greater than 85, with seeing the benefit of increasing that dose, they put this soft constraint of greater than 90 gray or less than 95 gray, and as the others that are listed. And similarly, originally in Embrace 1, they recommended that the rectum D2cc be less than 75 gray. From the Embrace 1 data, they saw that there was really an exponential increase in toxicity from 65 to 75. So in Embrace 2, they recommended that the rectum aim for less than 65 between external beam and brachy with a limit of less than 75. And similar for the other normals, they also kind of lowered or put forth a soft constraint or aim. And then they recently presented the outcomes for Embrace 2, which really showed excellent disease control that was actually even improving 17% from Embrace 1, and also very low grade 3 to 5 toxicity, GI, GU morbidity to less than 10%. Again, a significant improvement from what they found in Embrace 1, so that with updating their recommendations, they were able to improve disease control and decrease toxicity. Another key finding was the high use of hybrid or combined intercavitary interstitial image-guided brachytherapy. So in Embrace 1, around 43% of patients were treated with hybrid. And in Embrace 2, it was 74%, which is quite high. And Dr. Potter, when he presented this at Estro in the spring, said that this kind of represents the new standard of care for locally advanced cervix cancer. So Europe is really leading the way. We recently updated the ABS cervix cancer practice patterns, and we are also seeing increasing use of hybrid kind of in the US and Canada. It went from 4% in 2014 to around 30% presently, always using needles. And about 2/3 of practitioners add needles for more than 30% of procedures. So that practice is definitely increasing in the US, but maybe not to the same degree as in Europe. We also found from the practice pattern survey that there's increasing use of ultrasound guidance, going from around 32% to approximately 80% presently, and that practitioners who have ultrasound in the procedure room were more likely to use needles. Also, practitioners who have a high volume of cases were also more likely to use needles or follow a hybrid approach. We also saw increasing use of MRI to guide the first brachytherapy, going from 34% to 63%, and increasing use of prescribing to the high-risk CTV as defined by the JEC Estro group. So, what are the benefits of doing this hybrid or combined approach treatment? So, from the retro Embrace data, we saw that there's worse survival with advanced stage, which is kind of not surprising that, a larger tumor might have areas of disease that are outside of your traditional pear-shaped dose distribution. But from the retro Embrace data, we saw that there was a mix of how patients were treated. Some were treated with intercavitary alone, which would be tandem and ring or tandem and ovoids, and some were treated with a combination of intercavitary plus interstitial, so tandem and ring and needles or tandem and ovoid and needles. And they saw that those who were treated with that hybrid combined intercavitary interstitial approach were able to achieve a higher D90 to the high-risk CTV, and that this translated into improved local control, in particular for large tumors or high-risk CTV greater than 30 cc's. So just to explain a bit more of how adding needles can improve the dosimetry, if you have, this is just showing an axial cut with a high-risk CTV in green, the bladder anteriorly, the bowel posteriorly. And so if you have just the dose coming out from the tandem, as shown centrally here, you might have to balance the coverage of the high-risk CTV with the overdosing of your adjacent normals like the bladder and bowel. But with just adding a couple needles, you can improve the shaping of the dose so that you can both improve target coverage or coverage of the high-risk CTV and also decrease dose to those adjacent normals like the bladder, the bowel, or the rectum, depending on what level you're at. So you could definitely see the benefits of adding needles. So when do we think about adding needles? So as we talked about, so bulky residual tumor, so a risk CTV greater than 30 cc's. We also have data from the GEC Estro group showing that adding needles can be useful for lateral or wide extension, so parametrial pelvic sidewall disease. We'd also think about adding needles with vaginal extension. So your traditional intracavitary applicator is going to only treat the upper vagina. So if you have disease coming down the vagina, you need to think about adding needles to adequately cover the disease. And also for asymmetric targets. So actually, we recently looked back at our experience of small tumors, so less than 30 cc's. So we've been adding needles for more than 5 years now. And so our patients were treated with a hybrid approach, but we had them replanned with just using the intracavitary component, but maintaining the same normal tissue dose. And we saw that, not surprisingly, with the combination of the intracavitary interstitial, we could achieve a higher D90 with similar dose to the normal. So an asymmetric target can benefit from having this additional dose shaping. And similarly, the University of Cincinnati had also showed that with small targets, using hybrid can lower the dose to the normal. So either you're improving coverage or you're lowering dose to the normals. So how do you add interstitial needles? So we'll take you into the procedure room, right? You're working in the small area of the vaginal canal. Your tumor's up, at the top of the vaginal canal. You have to kind of navigate around the other equipment, the other applicator pieces. It's beneficial to use ultrasound, in particular transrectal ultrasound guidance. So your options about how to place needles, you can use, a freehand approach navigating through that area. It can be difficult to get the needles exactly where you want, can require repositioning. Other options are to attach a transperineal template kind of, on that vulva region. Again, you'll be placing needles far from the tumor, so it can be difficult to get the needles exactly where you want. Or there's different commercial applicators. Some of those are shown below. They tend to be vendor specific, and they have different ways of accommodating needles. And so it's, with them being vendor specific, it depends what kind of afterloader you have. And it's good to investigate these, but you also want to see how they will work with your patient anatomy. When we first started, adding needles, many years ago, there were more limited options, and we, got a few, but we found that they really weren't putting needles where we wanted. And so we developed other approaches to adding needles with 3D printed tools to help us. And other groups as well have developed 3D printed tools. Lindegard and colleagues from Denmark have developed with the 3D printed ring caps that guide needles either in parallel or parallel and oblique. And with that approach, they found very good local control. A group from Montreal has developed 3D printed ring caps. And then my group, along with Dr. Niedermayr, we have developed what we call the Target, or tandem anchored radially guided interstitial template, which are small 3D printed needle guides that we had attached where you traditionally attach the flange to help guide the needles. And we have been doing this since 2019. And about a year ago, we looked back at our experience and found that with using 3D printed needle guides or tools, our local control was significantly better than not, likely because with using the needle guides, we can more optimally place the needles to facilitate favorable dosimetry. And so our approach to procedures, since we have a number of different needle guide tools, the patients towards the end of external beam and before they start brachytherapy will have an MRI. So then I will contour out the area of the tumor. We'll assess the response to the external beam. And then we've actually scanned many of our 3D printed tools with all the needles in place. And we fuse that to the MRI to help guide us on where we want to place needles to cover the tumor extent at the time of the procedure. And a few years ago, we actually looked back at our experience of this more formalized pre-planning approach, and we found that with using this pre-planning approach, we were able to improve the dosimetry that we got at fraction 1 to similar to what we were getting at fraction 2, so that by taking advantage of all the information, we could improve the dosimetry at fraction 1 and thereby for all subsequent fractions in the overall brachytherapy treatment course. So, doing hybrid brachytherapy has a lot of things to think about. And so as was referenced, we recently published the ABS consensus guidance for hybrid intracavitary interstitial brachytherapy, which I refer you to. It's published just this year, in brachytherapy to kind of go through everything if you're starting a hybrid procedure. But just to give you a little hint of things that we think about, there's a higher bleeding risk when you're adding needles. So we will always check the blood counts, right? Because you have patients that are just coming off chemotherapies, so they have a high risk of being anemic, and you want to check to make sure they have adequate levels when you go into the procedure. We also want to check their coagulations to make sure that they have appropriate clotting, and then we would transfuse if necessary. If they're on anticoagulation, we would either hold or bridge with Lovenox. So we want to make sure that we have this procedure performed in a safe way. And then we also, go into the procedure with a plan about, what we expect to use in terms of the tandem angle, the tandem length, the ovoid size, the needle positions, and needle depth. So although we go in with this pre-plan about what we're going to do, it's not that uncommon that we will modify from that when we see something on ultrasound. So as I mentioned from the practice pattern survey, there's been increasing use of ultrasound, both transabdominal, which actually was slightly higher. I most commonly use transabdominal ultrasound to verify tandem placement, but I find the transrectal ultrasound is most useful for guiding the interstitial needle placement or for hybrid procedures. So this is just showing an example transrectal ultrasound image. You can see the dark outline of the cervix tumor, and then centrally this bright region is the tandem. So this is just the cervix tumor with the tandem place. And then as I place the needles, I'm looking as well to see where they're going and seeing how they're covering the tumor and where else I might want to add a needle to better cover the extent of the tumor. So using transrectal ultrasound with a hybrid procedure can be very helpful. So kind of our overall approach, right? We do have our pre-planning where we get the MRI before the procedure, contour out the tumor so we know what to expect, make a plan about, what applicator we're going to use, where we're going to place the needles, and then we go into the procedure, using transrectal ultrasound to guide us during that procedure about where the needles are going and where else we might need to add them. And then after the procedure, we do 3D imaging. At our institution, we do both a CT, which we can get very quickly, and we then generally contour the normals on the CT and trace the applicators. And then the patient also gets an MRI, which allows us to contour the region of the cervix, the high-risk CTV, and then that's passed off for treatment planning and then treatment. So as I mentioned from the Czech Ester group and their different studies, they've really learned a lot about the dose that translates into improved disease control, in particular the high-risk CTV D90. From this collection of studies, they found that there's really an association between the D90 and local control, and it's even more pronounced for the more advanced stage. And then additionally, I talked about the recommendation for the rectum, so that originally in the Embrace 1 study, the recommendation was to keep the D2cc max from the combination of external beam and brachy less than 75, but then they found that the risk of grade 2 rectal morbidity really increased exponentially from 65 to 75. So then they put forth the aim of 65 and the limit of 75. And similarly, they've found this for others, for the ICRU vaginal point and vaginal stenosis, and then the bowel 2cc and diarrhea, and then the bladder 2cc and cystitis, and the ICRU bladder point and urinary incontinence. So they've kind of really have the data backing up the recommendations for coverage and dose limits. So we got our first question. What are the key factors that contribute to cervix cancer local control?
But how long does usually procedure take? So you mentioned all the steps.
So usually we aim to do the procedure or have the applicator in time in that 2 to 4 hour range. It kind of depends how many other procedures we're doing. If we're doing more limited procedures, it can be about 2 hours, but if we've got I generally stack my procedures. So if there's a lot of procedures, then it could be, more like 4 hour applicator in time. Okay.
So we'll wait for a little bit more answers. So currently 66%. We also take attendance by them answering. So we want them to answer. So 80% answered. Thank you for answering. I'm ending the poll and sharing the results. So majority answered C.
Or C. Looks like 42% answered C, right?
Yes. Mm-hmm.
So that C is the
Correct.
C is the correct answer, right? So we want the high risk CTV greater than 85, maybe striving for 90, but less than 95. And then ideally we want, so we're aiming for an overall treatment time of 50 days or less, and with at least less than 55 days. And then we would recommend brachytherapy, not SBRT, for your advanced cervix patients.
Great, thank you.
And then another question, what is a documented benefit of adding interstitial needles to cervical brachytherapy plans for large tumors?
I've noticed that you have a vaginal rectal point, ICRU point, so it's not the volume. Do you usually also contour vagina and look at 2cc?
No, since the ICRU rectal point overlaps with the 2cc, it has that same limit. Mostly I find that by just tracking the rectal dose, you're kind of in some ways tracking that vaginal ICRU
vaginal dose. Okay, we have 81% answering. I'm ending the poll. Sharing results, a majority answered B, improve local control without increased toxicity.
Yes, that's the correct answer.
Excellent.
Yeah, so that we see this improved disease local control with adding needles, but no increase in toxicity, which is quite favorable. Right? So just to review about cervix cancer brachytherapy, it's made significant advances with transitioning from 2D to 3D with MR guidance, and image-guided adaptive brachytherapy with MRI shows improved local control and decreased side effects. There's increasing use of hybrid brachytherapy, with it being 74% on Embrace 2, and there's benefits of ultrasound guidance during procedures, particularly hybrid procedures. And overall, we recommend following the JEC Estro Embrace 2 guidelines for target volumes and dose constraints. So now we're going to move on to talk about vaginal cylinder brachytherapy. So when do we use vaginal cylinder? So it can be used alone as adjuvant treatment for high intermediate risk endometrial cancer, so patients who meet PORTEC-2 criteria. It can also be used as boost treatment, so given in addition to external beam for endometrial cancer patients with cervical stromal involvement or other high-risk factors. It can be used in the post-op cervix setting for large, deeply invasive tumors, vaginal involvement, closer positive margins, or extensive LVSI. And then it can also be used in combination with external beam for primary vaginal or recurrent endometrial cancer patients where the residual disease is less than 5 millimeters thick, and then that can adequately treat that area. So what does the ABS recommend? So they recommend that the treatment starts at least 4 weeks. Here at Stanford, we generally do 6 to 8 weeks after surgery. In particular, if you're doing, robotic or laparoscopic surgery, you want to make sure that that vaginal cuff is well healed before the radiation starts. They talk about different applicator selection kind of based on the tumor size. Most commonly, we use the vaginal cylinder. They also talk about when you're treating the upper vagina, that the cylinder should not, the full thickness cylinder should not extend to the introitus, so that you can have just the narrow part at the introitus, which is more comfortable for the patient, and it also helps hold the applicator in. In terms of their recommendations for use, again, they agree that vaginal brachytherapy is a reasonable substitution for pelvic radiation for patients meeting PORTEC-2. They do highlight that a high proportion of PORTEC-2 patients had low-grade disease. They recommend vaginal brachytherapy as a boost for post-op cervix with less than radical hysterectomy, close or positive margins, large or deeply invasive tumor, parametrial or vaginal involvement, or extensive LVSI. In their approach or technique recommendations, they recommend performing visual inspection of the cuff to ensure that it's well healed and there's no recurrence, and then also to assess the shape or width of the vaginal apex. They recommend placing a radiopaque seed or clip at the apex. We generally place a couple gold seeds kind of just outside the area of the scar so that, again, that we can see that, sort of see the scar on imaging. They recommend using the largest diameter cylinder that can comfortably fit to optimize dosimetry, both in terms of minimizing air gaps and decreasing vaginal mucosa dose. And then after placement, they recommend using some sort of external immobilization to minimize movement of the applicator from placement to treatment. They also recommend trying to have it mostly horizontal to minimize dose, so it's not more angled towards the bladder or rectum. And they recommend using imaging. We generally use CT imaging, again, to verify that the applicator is up against the scar or the gold seed, and confirm no air gaps. In terms of what people do, there was an ABS practice pattern survey from a bit more than 10 years ago. Most people treat a fixed length of about 4 centimeters. It's rare. Most practitioners never treat the full length of the canal. In terms of imaging, again, this is from about 10 years ago. About a third use X-ray imaging and about a third use CT imaging and a third use no imaging, but we really would advocate for doing imaging to verify that the applicator is placed as you think up against the apical scar. In terms of dosing, so if vaginal cylinder is being used alone as adjuvant treatment, the most common dosing was 7 gray times 3 prescribed to 5 millimeter, which is the Portec 2 dosing. If it's used as a boost along with external beam, interestingly, the most common dosing was other, but then the second most common was 5 gray times 3 prescribed to 5 millimeters. We actually use 4 gray times 3 prescribed to 5 millimeters, mostly because if you VED it out using the combination of external beam and the 5 gray times 3, it's actually a pretty high dose. So you can, safely do a slightly lower dose. So our next question, vaginal cylinder brachytherapy alone is commonly used as adjuvant treatment for.
And Beth, in terms of planning, I'm not sure if you're gonna show this, but you replan every fraction or you evaluate?
We do replan every fraction, mostly because the planning's pretty quick, but it is variable by institution. Some institutions kind of use like a planning library and maybe plan the first one and then use that same plan for the subsequent.
Yeah, that's what we did at Mayo. And is there a paper that maybe shows the benefit of replanning each fraction, or maybe you evaluated it?
I'm not sure. I mean, sometimes there is some variability in the normal tissues, but I think it's, it's kind of small. Mostly I'm going to repeat imaging because I want to verify placement, and, the actual planning is quite quick, so.
We have 84% answering. I'm ending the poll, sharing results. So majority answered B, high intermediate risk endometrial cancer.
Yes, that's the correct answer. That's who we should use it as vaginal cylinder alone, meeting Portec 2 criteria. So just a quick summary. So vaginal cylinder brachytherapy is used on its own for high intermediate risk disease, meeting Portec 2 criteria, used with external beam for high risk features such as cervical stromal involvement, or as a boost for primary recurrent vaginal disease that's less than 5 millimeters thick. You ideally want to use the largest comfortable cylinder to optimize dosimetry, and there's benefits of image guidance in particular to verify appropriate placement. So now we're going to talk about interstitial brachytherapy. The main indications is used, as a boost or in combination with external beam for primary vaginal cancer, recurrent endometrial or recurrent cervix cancer that has a vaginal recurrence, or isolated vaginal metastasis. So primary vaginal cancer, just for some background, is actually quite rare. Things that are important to know is if patient had any history of prior GYN cancer, it would likely be classified as like a recurrence from that cancer. Additionally, if the tumor is invading either the cervix or the vulva, it would also be classified as cervix or vulvar cancer. So that's also kind of why it's fairly rare. mostly squamous histology, mostly HPV related. Given the rarity, there's no randomized trial, and so treatment is generally based on institutional series and extrapolated from cervix, vulvar, and anal, which are also HPV-related squam cancers. So the workup, history and physical with the pelvic exam and biopsy again to confirm histology and assess the extent of disease and assess that it's not involving the cervix or the vulva. And then your general labs because of the risk of bleeding. And then generally, because it's a squam, PET-CT can be useful to look for nodal disease or distant disease. But for looking at the local extent, we generally want an MRI with T2 series being the most useful. When we get our MRIs for our either vaginal patients or anyone with a vaginal component of disease, we generally will put gel in the vagina because that helps show the vaginal extent of disease. It's shown here, the gel shown in white, and then the tumor is dark. And then in terms of prognostic factors, we have tumor stage. The more advanced stage does worse, larger tumor size does worse, non-squamous histology has a worse outcome. And then in terms of treatment factors, there's data showing benefits of concurrent chemo, benefits to brachytherapy, and also benefits to dose. So historical data showed a benefit to EQD2 combination dose between external beam and brachy greater than 70. And then we have newer data from Retro and Brave, which we'll talk about, that shows a benefit to greater than 80 gray from the combination of external beam and brachy. In terms of how treatment, the treatment approach is generally individualized based on location, size, and stage, but most commonly, only very small upper vaginal tumors can be resected because a resection in most places of the vagina would require an exenteration. So anything that's larger than 2 centimeters or in other parts of the vagina would most commonly be treated with definitive radiation. And usually the radiation is going to be, the pelvic radiation to around 45 gray. If the disease is in the distal or kind of lower half of the vagina, we would also include the inguinal nodes. And then we will add a brachytherapy boost to get a total EQD2 dose of 75 to 80 plus gray. How we do that brachytherapy depends on the tumor thickness at the end of external beam before starting brachy. So if the tumor is fairly thin, less than 5 millimeters, we'll use a vaginal cylinder or multi-channel cylinder. If the tumor is thicker than 5 millimeters, we'll use interstitial. And then in terms of using concurrent chemo, there's NCDB data showing increasing use of concurrent chemo and that there's improved survival across all the stages as shown in green with adding chemo. So generally we would recommend adding concurrent chemo during the external beam portion of radiation for your primary vaginal cancer. As I mentioned, the data is pretty limited for vaginal cancer, mostly institutional series. One of the largest series comes from MD Anderson of close to 200 patients that was published about 20 years ago, a range of stages. But they do show that outcome, correlates with stage. Larger tumors do worse. But overall, there's a mix of local and distant recurrences, but overall, there was a high rate of local regional recurrence. More recent series have started adding chemotherapy, with the largest series being from Miyamoto, which included 20 patients who had chemoradiation and then 50 who were treated in an earlier time period with radiation only. They do show improved survival and disease-free survival with the addition of chemo and lower rates of recurrences. They also note, though, that those patients who were treated with chemo were treated more recently, so probably also had other benefits of imaging and image guidance. So when they look at, the analysis for factors that influence disease-free survival and overall survival, we see both date of diagnosis, chemotherapy, tumor size, the inclusion of brachytherapy, dose to the vagina greater than 70 gray EQD2 from external beam and brachy, and then the combination of external beam and brachy. We also have SEER data that shows a survival, both the overall survival and disease-specific survival benefit from the inclusion of brachytherapy in the treatment of primary vaginal cancer. On multivariate analysis, independent of stage, tumor size, and histology, we see the benefit of inclusion of brachytherapy, and patients who have a tumor more than 5 centimeters had the most significant benefit from brachytherapy. This is just showing dose recommendations from more than 10 years ago from ABS, from the combination of external beam and brachy. But you see that most of the EQD2 is kind of in that 70 to 80, or, kind of in that 75 to 80 gray, from the combination of the external beam and brachy. More recently, Jack Estro has put forth target volume recommendations for image-guided brachytherapy for primary vaginal cancer. Again, they recommend assessing the extent of the tumor at diagnosis and at the time of brachytherapy, both clinically and on T2 MRI. And then they have put forth recommendations about target volume, so that you have your GTV residual, which is sort of the that's shown in white, the macroscopic gross residual tumor at the time of brachytherapy from clinical exam and imaging. Then you have the CTV high risk, which is encompassing the whole GTV residual and any abnormal vaginal wall within the initial tumor extent. And then you have the CTV intermediate, which is sort of all significant microscopic disease adjacent to the high risk CTV. They also recommend contouring the vagina, as shown in light blue, outside of your target volume, because in some ways it's an area of exclusion, because if you treat, there's a lot of morbidity if you're treating the whole vagina. So that you'd also want to think about different dose volumes for that. Kind of different than cervix, where we treat the whole cervix, but here we are treating a portion of the vagina, and then want to think about trying to minimize or have a lower dose to the uninvolved vagina. Similarly, Jack Estro has put forth kind of similar recommendations for either recurrent endometrial or cervix tumors that are involving the vagina, that again, assessing the extent of the tumor both at diagnosis and at the time of brachytherapy using the combination of clinical exam and MRI. So it's pretty parallel, just a different tumor as opposed to primary vaginal, but very parallel to the primary vaginal recommendations. And then there have actually been groups, in particular in Europe, who have followed these image-guided brachytherapy approach, the largest series being from Westerveld et al., which is from 5 European centers of almost 150 vaginal cancer patients, with the majority having T2 tumors, again, vast majority having squamous, a mix of less than 4 and more than 4 centimeters. About 2/3 had concurrent cisplatin. Only 38% were treated with IMRT. The vast majority were getting pulse dose rate, and the other group was getting high dose rate. I think it's just a European factor that there's a high amount of pulse dose rate in Europe. In the US, it's like mostly all high dose rate and very minimal pulse dose rate. Most patients only had one insertion, so almost 70% had one insertion, one procedure, but a high portion with MRI at the time of brachytherapy. And then 55% had the combination of interstitial and intercavitary, meaning a thicker tumor, and then 45% were treated with intercavitary only. But they had very favorable outcomes. So with almost 3 years of follow-up, the 2-year local control was 86%, so much more favorable in those older series. And then the grade 3 or greater toxicity was also quite reasonable, less than 10% GU, less than 5% GI, less than 10% vaginal. They did note worse disease-free survival overall for your node-positive patients, kind of not surprisingly. And then in Niedermayr analysis, they see, significant difference in outcome between your early stage and your more advanced stage, and your small tumors and your more than 4 centimeter tumors. And then the lymph node status was both in univariate and multivariate analysis. And then they also noted improved local control for T2 to 4 tumors who had a EQD2 greater than 80 gray, as shown here. This is for the whole cohort, which was not quite reached statistical significance, but when they just looked at T2 to T4, they see a significant difference in outcome by having an EQD2 greater than 80 gray. And then what about endometrial recurrence? So for your early stage endometrial patients, for all comers, the risk of recurrence for those who don't get adjuvant treatment is about 10 to 15%. From PORTAC1 and GOG99. The vast majority of recurrences happen within the first 2 to 3 years. Those who have lower grade disease and outer 50% myometrial invasion are more likely to have a local regional relapse, whereas those with grade 3 disease are more likely to have distant relapse. And while the vast majority happen within the first 2 to 3 years, you can see relapses later. Again, the workup is similar to primary vaginal cancer, right? You want to biopsy to confirm recurrence, get imaging to assess the extent of disease, rule out distant disease, and then if the disease is localized to the vagina or has a vaginal component, to get a pelvic MRI to look at that local extent of the vaginal disease. From the PORTEC data, we see that, a high proportion of your vaginal recurrences are salvageable as compared to your pelvic recurrences, which perform similarly to metastatic disease. Additionally, patients who have not previously had radiation are more salvageable because radiation is a potential treatment option for those patients. Recently published data from the NRG GOG study 236 showed that there's not a benefit of chemotherapy for endometrial recurrences. So the patients were randomized to radiation only or radiation plus chemo. Important things to note, the vast majority of people in the study had vaginal only recurrences, and the vast majority were low grade, grade 1 or 2. But in that population, there was no difference in outcome from radiation only or radiation plus chemo. So for your endometrial recurrences, there's no benefit to adding chemotherapy. In terms of radiation, again, if they're radiation naive, we would generally, treat the pelvis to 45 gray. Again, if the vaginal recurrences is in the low vagina, we would include the inguinal nodes. And then towards the end of the external beam, we assess the response and the thickness of the disease and do some type of brachytherapy depending on the thickness. Again, aiming for a cumulative dose between the brachytherapy or the external beam and brachytherapy of 70 to 80 plus gray. If the patient has had previous radiation, it really needs to be individualized based on the previous radiation dose and interval from previous radiation. In terms of approaches for doing radiation or brachytherapy in this population, so again, if the tumor is less than 5 millimeters thick, they can be treated with a vaginal cylinder or a multi-channel cylinder such as the Miami. If the residual disease is greater than 5 millimeters thick, the treatment would generally be interstitial plus intercavitary. The needles can be placed freehand or with a perineal or other template. They're just showing some of the more common templates available. This is the Syed, which I think is kind of the most common, and the MAC, the Kelowna, Venezia, because you can use these without the tandem. But generally, there's a cylindrical component and a perineal component for adding needles. One thing to bring up is, I think oftentimes what people get worried about when you're adding needles is what happens if the needles get into adjacent normal tissues, bowel, bladder, rectum. And we have some useful data from Dr. Leung and colleagues at Sunnybrook that looked back at their experience with a decent number of patients who did have needles that went into these normal tissues and saw that there's really, as long as it's recognized and now the needles that are in those normal tissues are not treated at that area, there's really quite low rates of toxicity. So the thing that's really important is doing the imaging to recognize where those needles are and not treating within those normal tissues, and then your risk of toxicity is quite low. And then I also want to talk about how we approach our interstitial cases here at Stanford. For a while, we've been approaching them different than the traditional perineal template. We felt that when you attach the template to the perineum, the vulva area, you have several disadvantages. You're often quite far from the area of tumor. And when you're far from the tumor, the more the needle has to kind of go through the tissue, the more it can veer, and it can be harder to get the needles where you want. Additionally, a lot of primary vaginal tumors or recurrent endometrial cervix tumors that are involving the vagina can be seen quite easily on speculum exam. And when you put that template on the vulva, you're taking away the benefit of direct visual guidance. So we wanted an approach that would allow us to use direct visual guidance. And so we designed a template that we call simple needle attachment post-placement that allows us to use transrectal ultrasound guidance as well as direct visual guidance while we're placing the needles. And then once the needles have been placed, we can attach the template and then the needles can be secured with sort of a click fit approach. They're kind of snapped in, and then there's an additional locking cap. And then this template can be sutured to the perineum, similar to your other traditional perineal templates. It can accommodate a cylinder. It's MR compatible and sterilizable. So, we started using this several years ago and looked back at our experience compared to historical patients that were treated with commercial templates. And we found that with the SNAP-IT approach, the needle insertion depth was about 2/3 the historical, because we were inserting kind of directly into the tumor instead of from the perineum to the area of the tumor. And we saw the procedure about 20 to 30% quicker, and we had still similar excellent dosimetry, but a kind of more simpler, easier procedure. We've also developed a 3D printed approach for interstitial procedures. So historically, we actually were using this. We would do 2 implants. The first procedure, the patients would get the SNAP-IT, and so then we would have an MRI with the cylinder in place. And then a week later, we would do the VIA, or vaginal individualized applicator, which is a 2.5 centimeter cylinder that can accommodate up to 20 needle channels that are individualized based on tumor anatomy. So this is just showing an example of kind of very spherical tumor. And then, here's a more elongated tumor. So the needle channels, are modified to, the particular tumor anatomy to help cover the extent of the tumor. And we saw that with using this VIA approach, the procedures were about 50% quicker than our, freehand approach, but still excellent dosimetry. So now for our first question about interstitial brachytherapy. What EQD2 dose level is associated with improved local control for T2, T4 vaginal tumors?
These applicators, SNAP-IT and VIA, are they patient-specific, or they can be made patient-specific?
So the SNAP-IT is sort of just a general, right? Because it's like we place the needles freehand and then they're secured to that. Whereas the VIA is patient specific. So we design, we have like a set, approach with a 2.5 centimeter diameter cylinder, but the needle channel angles are individualized based on the tumor anatomy.
Okay, so we have 80% answering, 84. I'm ending the poll. Sharing result. So majority answered C, more than 80 gray.
Yes, that's the correct answer. Okay. And then just to conclude on this, for both primary vaginal or recurrent endometrial or cervix tumors that are involving the vagina, we want to have the initial assessment of the disease extent, both a clinical exam and imaging. Concurrent chemo may be beneficial for primary vaginal cancer, but has been shown not to be beneficial for recurrent endometrial cancer. Generally, the treatment is going to be a combination of external beam and brachytherapy, and we choose the type of brachytherapy based on the thickness of the disease at the end of external beam just before starting brachytherapy. We recommend using T2 MRI and image-guided adaptive brachytherapy. And then from the retro and brave data, we see very favorable local control of 86% and the improved local control for T2 to 4 tumors if the EQD2 is greater than 80 gray. Right, so that concludes my portion. And now Dr. Niedermayr is going to talk to us about planning and 3D printing.
Excellent. Thank you so much, Dr. Kidd. That was very fantastic and expertly delivered lecture. You see it from responses to the questions. Everybody got it. So thank you for teaching. Thank you.
All right. Can you see my screen?
You need to, yeah, perfect.
We're good?
Yeah.
Great. So I'm going to switch to treatment planning in GYN brachytherapy. And the first thing I want to say is this is not a substitute for a good implant. You are not going to be able to save your dosimetry simply by dragging on isodose lines. You really need to have a good implant. And as you've seen from the work Dr. Kidd and the group here has done, you spend a lot of time on optimizing the implant. If you have good geometry of an implant, you will have good dosimetry most likely. So what are the goals in treatment planning, just in brachytherapy? The first step is, as a dosimetrist, physicist, you will get a CT or an MR, and you will have to reconstruct the applicator. That means you need to be able to see it. On CT, you can put in some wires. I show here on the side, these are needles that are inside a tumor, and you see those white dots. These are the needles, because during scanning, we put a wire in. On the afterloader, every time you have a source exchange, you get what is called the dummy wire, the wire that does not have any radioactive source. And as you collect them, you can use them. They're very nice to use because they don't create a lot of artifact. The ones that typically are offered by the company are nice and bright, but they can obscure the adjacent tissue that you're trying to contour. So first step is defining what your degrees of freedom are, where in the patient you will be able to put the source in and put dose. The second step is you're going to optimize those positions by using them more or less in order to custom shape a dose to satisfy the prescription dose and the OARs. Very important here in the US is all the checks and balances that we have. And we have a 3-to-1 approach here where we look at the 3D volumetric metrics that are standardized. Dr. Kidd put forward, for example, for cervix, the Embrace 2. I'll talk about these a little bit later. Then we have some rules that are institutional for what we accept in terms of isodose lines, hotspots, or a 2D approach. And then finally, we review the plan integrity, safety. The obvious thing that can go wrong in brachytherapy is if you have a channel length that is different than what you have in physically. So if in the treatment planning system, you say my channel length is 130 centimeters, but you really have 150, when you deliver, you are going to deliver this in the wrong location. So 3-to-1, and then you're ready to treat. So GYN brachytherapy in particular. So what's special about GYN brachytherapy is the variety of tumors and topologies that you can have. And that also is shown by the number of channels that are used, down to 1 from cylinder brachytherapy up to 20 plus for complicated interstitials or even for complicated cervix tumors. And this is what starts everything. This defines the degrees of freedom. This can make or break your dosimetry. The targets are now typically volume, as you've seen. These are contoured, typically on MRs, if you have an MR where you have the best visualization, or on CT. The OARs typically are the rectum, bladder, and bowel, which sandwich the tumor and need to be avoided. Normalization, how we define and measure the prescription dose and how we start the planning. It can be various way. It can be with a point. We'll talk about point A in cervix brachytherapy. It can be a line. It can be a volume, or it can be all three as you progress in the planning. One thing I want to put forward here is you've seen in previous lectures already that treatment planning in brachytherapy can be quite different from external beam. The dose calculation is much simpler, and you can actually drag, meaning move dynamically isodose lines in all treatment planning systems now. So that typically creates a hybrid approach, different from the external beam, where, for example, in IMRT, you would contour everything that you want covered, define the dose levels, and let the optimizer give you a dose. But typically, this is not a one-step process. There is a back and forth there, where then you need to talk to the optimizer by doing more contouring. Here, the patient is uncomfortable, is getting medicine, drugs in order to be able to go through treatment. The applicator in is rather uncomfortable, so speed is important. And so there's a hybrid approach where you can do some optimization to get you started, and then some manipulating of the isodose lines, to get to the result. And as an aside, many centers rely on the AAPM protocol TG43 for dose calculation, which assumes that everything is water. This seems rather simplistic, but considering that we are within the tumor and the normal tissues that we care about are very close, there is very little inhomogeneity, and so this is sufficient for most cases unless you use shielded applicators. So here's an example of cylinder treatment planning. So this is a snapshot of the Brachyvision. So this is a variant product for planning brachytherapy treatment. So we have our three views here, the axial, coronal, and sagittal, with the cylinder that you can see is a little bit radio opaque. And we have our isodose lines. The yellow one is the prescription isodose. And on the side here, you see the dwell times. So these are the location within the applicator where the source spends time, and you can interactively manipulate these. And on the bottom here, we have our templated clinical goals, which as you dynamically change the plan, you can verify if you are within the constraints you've set yourself, both for the target and for the normal tissue. So the first step is to reconstruct the applicator in the cylinder. It's obviously the simplest. There is only one channel, and you have to find the most important part is where is the end of the channel. Here it's quite easy to see because there's an air gap. In other applicators, it might be a little bit more complicated, and physics will have to work during commissioning to be able to find a relationship between what you see on the CT and where the first position of the source can actually be. You see here in the channel, it's been reconstructed a number of rectangles. These are all the sources, potential source positions. The source that we have here in the variant Bravos is about 3.5 millimeter long. So we separate our source positions by 4 millimeters. There is no need to overlap. It does not give you an independent optimization point. So these are all the potential places you can put the source, and with also the other degree of freedom that you have in high dose rate brachytherapy, which is how much time you spend at each, you can really customize the dose to the target. So what is the target in the cylinder? It is a shell, 5 millimeters around the cylinder. That is the target. So it's a volumetric target. And the normals, as you see here, is the rectum, the bladder, and the bowel. So you can interactively change the time, and here is what typically you will get in terms of a time distribution for a vaginal cylinder. It's a so-called dumbbell distribution where the tip and the bottom are more weighted simply because within the cylinder you have dose contributions coming superiorly and inferiorly, and you don't have any additional contributions when you're at the tip of the applicator or at the bottom of the applicator. So as you've heard, we plan every fraction of the cylinder. You don't necessarily have to do that, but you do certainly have to image in order to be able to see if your applicator is at the end. And so you could use a template for each and every fraction, because what you are doing, you are always shaping the same dose volume around a cylinder of a certain size. So they are template based, or you can have a dynamic graphical approach to achieving your goals. And the one thing I wanted to mention is what Dr. Kin mentioned earlier. We tried to put the largest applicator in, both for air gaps, but also for sparing the vaginal mucosa. Why is that? So I'm showing here the dose fall off 1/r square of a point dose. And what this tells you is how much dose falls off versus the size of the applicator. So what we're looking at here is an axial cut in blue is the 200% isodose line. This is the isodose line that we're trying to keep off the vaginal mucosa. And in yellow is the isodose line that we care about, is the prescription dose. So the distance between this blue line and this yellow line is set by the size of the applicator. If you have a very small applicator, what will happen is the dose will fall off very quickly. Whereas if you have a large applicator, you will see the distance between the fall off between those two isodose lines is going to be much more shallow. So it's going to be also easier to reach, and you have a flatter dose fall off if you use a larger applicator size. Switching to tandem and ovoid. As you've seen, historically, it's been an applicator-based dose distribution. On radiographs, you could not see the target or the normal tissue very well. And so all the rules over the decades that this treatment has been delivered with low-dose brachytherapy has been applicator-based. And the tandem ovoid shown here in situ has one particular point called point A, which is a prescription point, a point where you're trying to give the dose, but is also an area we're trying to limit the dose, the ureter and the uterine artery. So classically, in order to get a tandem and ovoid dose distribution, what was done previously when low dose rate sources were used is the applicator would be loaded with radium or cesium sources of relative dose strength. And this the relative loading is dependent on the applicator size. So here you see tandem and ovoid with a tandem loaded with 20-10-10, meaning the source at the tip was twice the activity of the two subsequent sources. And if you had small colpostat or small ovoids, you would load them with the same activity as what you have on the bottom here. And as you increase the size of the colpostats, the ovoids, you would be able to place larger sources. This is all to get a certain dose rate at point A, about 60 centigrade per hour. And so we have a lot of data follow up from this approach. And so when we switch to HDR, we try to mimic this in planning, at least first order. So when you have a TNO and you have a tandem and ovoid applicator inserted inside the patient, again, we have this view here with our three axial sagittal coronal view, the DVH and the dwells. You will load in time to relative loading similar to what the rules that I showed you before. So a 2-1-1-2-2, for example, would be the loading. And what we're mimicking here, we went even further in mimicking the spatial length of the loading because those cesium sources were 2 centimeter length. We have a source in brachytherapy here on the HDR Bravos, which is about 4 millimeter long. So if we have 5 steps separated by 4 millimeters, it's about 2 centimeters. And so we are mimicking what was done previously in the LDR times by mimicking this with HDR times. So the initial step in tandem ovoid treatment planning is to define this relative loading after you've reconstructed the applicator, define point A, and then scale the dose in order to give 7 grade to that point A. In this situation here. And what you see then, you get a pear-shaped dose distribution. Now, the tandem might be of different length, so you might have to do some fine-tuning. Not every tandem is 6 centimeters long. Some are shorter, some are longer. So you might have to do a little bit of tweaking, but that is the first step in terms of classical dose distribution for the pear-shaped dose. Again, it's only applicator-based. The needles have not been taken into consideration yet. What you see here is the clinical protocol that we use, which defines the dose we want to give to the CTV, the D90 that's been mentioned previously. And we get a very good D90 because we have a lot of dose, but the bladder and the bowel, as you can see here with the overlap of the yellow isodose lines on the bladder and also on the bowel, we are above our 2 cc metrics that we're trying to achieve. And that is typical. So step 2 will be, again, only working on the intracavitary component and trying to minimize dose to the organs at risk. This typically means kind of reducing the dose at this interface here where the tandem pushes dose out into the bladder and into the sigmoid or bowel. And so by manipulating that dose, not touching the dose in the ovoids here, by manipulating that dose, you can get your normals to be within the constraints that you set yourself. The trade-off there is simply that the dose to the tumor will then drop, and it can drop then under the goal that we set ourselves here. One thing I want you to notice is the 200% line that we cared about in the vaginal cylinder case is also contained within the applicator again. So the third step is adding the interstitial needles, and I'll switch between the two. You can see here we had a circular dose distribution with only 1 degree of freedom. As we use the 4 needles that we have available, we can shape the dose more closely to the tumor, and we can achieve both the goal to the target and to the normal tissue. This is typically done manually by adding dose in the location where the needle intersects with the target and manually changing the time in order to optimize the dosimetry. The total time that is in the needle is typically 10 to 15% of the total time, which might seem not very much, but because those needles are directly within the tumor, they have a very large effect in being able to achieve the dose goal to the target. So you need to take into account the whole treatment, and you've heard about these Embrace 2 trial constraints. The aim that we have for the D90 of the high-risk CTV is more than 85 gray, and you've answered the question correctly, so you know that already. We typically look but don't are guided by the D98, and a trial was shown that because there are so many differences in contouring between physicians, that the D98 is not as good a guide as the D90. And for the OAR, we have aims and limits. And so the aim is we would like to be under the aim. So the D2cc is the metric that we use for the bladder, rectum, and bowel. But we have to be under the limit. For example, for the rectum, once you go over 65 gray, you're going to have, 4-5% chance of rectal bleeding. But if you go over 75 gray, then you have, a percent or 2 chance of having a fistula. So the limit is a red line, and the planning aim is something we would like to. This is how it looks in a spreadsheet where we cumulatively add the external beam dose with the brachytherapy dose from each and every fraction. And because we have 4 fractions and we want to know what the sum dose will be, what we typically do is we're on fraction 2. We will then simply assume we're going to give the same dose both to the normals and to the tumor on the subsequent fraction, so we can make a good assessment of how we're tracking the dose over the whole course of treatment. So this is not automated, but we're able to automate it using the scripting that we have in our variant treatment planning system. So you can, at every step then, figure out not only what you're planning for this particular fraction, but also how this relates to the total dose for the patient. And lastly, the most degrees of freedom is for interstitial planning. So when you have no intracavitary component and you only have needles, and now you are set with so many degrees of freedom that manual planning might be difficult. You can approach it manually by simply putting a set time, a small time in each needle that is intersecting with a target volume, and then manually change the dose by dragging isodose lines. This is a rather long process. The other option is closer to what you can do in external beam, which is using an optimizer. Where you can let the treatment planning system dynamically change the location and the time in each and every needle for the source to dwell and look at the effect on the dose. And so this is more typical of what you see in external beam, where you set some constraints, some maximum constraint for the normal tissue. You set a minimum constraint for the tumor, for the HRCTV, and you can also set some constraints in terms of maximum dose. Typically in brachytherapy, we were very different. In external beam implants, 10% hotspots is huge. Here, having 10% of 200% is considered low inhomogeneity. So that's for treatment planning, a little overview. I wanted to tell you a little bit more about our 3D printed tools. As you know, we try very hard to make the best implant possible, because with the best implant, you're going to get the best dosimetry. So I'm going to lead you through the steps here in order to succeed with a 3D printing program, in terms of what are the material choices, the QA process, design workflow, and printing. Here's a collection. Every color is a different material. And all types of objects that we've created for general or custom application. So when we started, there was not much out there, but some companies were starting to print titanium, also doing hip implants, 3D printing them. So we allied ourselves with someone who was doing that already in order to start the printing. Because we had some in-house printers, but really these were made to print out bowlers or toys, and those were not really printing medical devices. So we first started by partnering with a company, and one of the two real important things is biocompatibility, because these are in contact inside the patient with a mucosa, for example, and sterilization. So they are different classes of material that certify their biocompatibility. In the US, it's USP Class 6. And internationally, there's an ISO 10993. And with that, you are certified that you could actually permanently or semi-permanently implant these into a patient. Sterilization, all types of sterilization approaches, from electron beams to gamma rays to ethylene oxide. We use steam sterilization. This is probably the simplest. Delivering 32 kilogray with our machines would take a very long time. So when you print these, you have to first start a program and assess that the materials are doing what you expect them to do in terms of dose. In the beginning, we were just using them to push needles, and then we've been starting to dwell within the 3D printed applicator. So dose measurements typically are done with film or ion chamber, and obviously with a CT, you can see the water equivalency. To remind you, we use TG43 water equivalency, and these materials can be water equivalent. Mechanical integrity is very important. The procedure room and within the patient is a demanding environment, and the 3D printed tool needs to not only fit, but also be able to manipulate well within all the apparatus that is typically in that environment. So once you have printed something, you need to test it with other applicator pieces. In our case, we slide over the tendon tandem? Can it slide smoothly? Can the needles go through the hole? Do they go in the locations that you expect? Can it be secured into the tandem? Are things MR compatible? If you use an MR, these are all things that you need to think about. And some of the QA is doing commissioning. Some of the QA will obviously be patient specific. When we design our templates, our needle guides, we have now a collection of predefined geometries, which offer multiple needle positions. So when you are in the procedure room, you know which ones you use, but you might want to use some if the anatomy presents differently when you use ultrasound imaging. So by having more options, you are going to be more adaptive during the procedure and be able to take full advantage of that particular fraction to deliver the dose you're trying to. When things get more complicated, you can import the contoured tumor into the CAD software from the MR, typically either pre or after a certain fraction. I'll tell you a little bit how that's possible in terms of timeline and how quickly we can print. So these can be then customized to the tumor, to complement nicely the dose distribution from the intracavitary applicator. So the 3D printing, now we're doing it in-house. And we have Stratasys. We used Stratasys previously to have them ship our designs. Now we use the Formlabs Biomed Clear, and we can print very quickly our own designs. So after the print, you need to wash these in an alcohol bath. This is a UV resin, so in order to harden at its final stage, you need to put this in an oven, and then you need to finally finish it by tapping if you have any screws or polishing it so there's no sharp edges. So there's a few steps. It's not just like in a printer. You just pick up your print from the printer and you're ready. So all this can be done fairly quickly. If, for example, we have a patient who on a Tuesday has had an implant and we need to customize, the design can be done that afternoon, sent for printing, and then the next day it can be ready to send to sterilization. And the sterilization typically can be done quickly, but we are separating our fractions. So what I'm saying is you can do customized 3D printing from fraction to fraction if you need to. The cost is very low, and we only use those devices patient specifically, so to avoid any other cross-contamination. So other people have approached this, and there's a workflow. It's fairly straightforward. You can do pre-planning. Ideally, you have an applicator in place. In an interstitial case, for example, you can have a cylinder in there, and when you image and contour, then you can design a custom a cylinder with needle guides. And this can be done, as I said, very quickly because we can print that in-house. All the quality control and sterilization can then be done in a day, and then we're ready for the procedure. So really in 2 days, you can go from pre-planning to having something ready for clinical use if you have something in-house. So to finish this section, I have a question on treatment planning.
Thomas, do you mind reading? So it's going to be also
sure.
subtitled.
Which parameter is most commonly adjusted during HDR treatment planning? So A, the source activity, B, the dwell time, C, the normalization point, and D, the dwell position spacing.
Well, they are answering, how long did it take you to come up with these designs for applicators? And was it some type of inverse planning or it was forward planning?
So typically there's a problem during a procedure, and then you think, we need to find a solution. And it's really a back and forth between myself and Dr. Kidd trying to find what would work best for that particular patient. So there's a back and forth there. So this is how things were started, and not every design works right away. So you need a physician who's able to deal with the consequence of a suboptimal design. Otherwise, you're not going to be successful. So there's a lot of back and forth. But now we have mature designs that have been tested through years of service, and so it's rather quick now to do this. This is still forward planned. From the experience we have, it's clear where we want the needles. Typically, you just point and say, "I want the needle here," either during the procedure or during treatment planning. You're like, "Oh, I wish I had a needle here," and so this is what we do. Is there room for improvement? Absolutely. I'm seeing that we are still 78%.
Yeah. So waiting for that one person to
we
answer.
did it.
Yes. So ending the poll, sharing results. So majority answered B.
And the answer is
B.
B. Absolutely.
It's impressive that all the answers actually are correct. That's, I think, the first time in the history of this course. Excellent.
Maybe the questions were too easy or the teaching was just really excellent.
I think the later. Excellent.
So let me finish then. Answer is B. And to finish, to conclude this section, so treatment planning in brachytherapy is highly individualized already with the applicators that we have. There's many pieces to customize to the patient anatomy. Embrace 2 provides a comprehensive framework for cervix cancer in terms of treatment planning by defining the targets, in terms of dose that we need. And again, the applicator choice really defines the possible dose distribution. We haven't touched upon it, but you will get a different dose distribution from a TNO than you will get from a Tenorman ring, for example. So you are going to be a little bit constrained in what's possible by the choice of applicator, which is also a little bit the choice of a company you go with the afterloader. But that's for another day. 3D printing enables really the next level of customization, and we've been able to do this safely and with improved outcomes. And I couldn't finish without saying Slava Ukraini.
Heroyam Slava. That's excellent. So I wanted to ask you. I would like to open the floor for discussion, but in the meantime, maybe when Sri, if you want to ask questions or anyone else, please ask questions or type questions in the chat. I wanted to ask you about timing. So to get a procedure, like the time for procedure when patient is in and out of the clinic, how long does it usually take for, let's say, vaginal cylinder, TNO, or TNO plus needles?
You mean how quickly to get them scheduled?
To get them treated, right? From imaging all the way till the end of treatment for one procedure.
I mean, so cylinder is very quick. So, right, we can do a cylinder and, from procedure to treatment and applicator removal, like less than an hour. For TNO, we've done it in less than 2 hours, but probably we average about 3-hour applicator in time. The actual procedure probably averages in that 30 to 40 minutes. And then, there's the imaging and planning. Planning can also range from 30 minutes to an hour, kind of depending on the complexity of the plan. The MRI is another 20 minutes or 30 minutes. So there's the different components, right? The cylinder has less components, right? Because we just do a CT and, only one applicator or one channel to track.
Yes, it's very quick. And another question is anesthesia component. Do you mind commenting on anesthesia?
Yeah, so cylinders, we just use like an oral pain med and a relaxing medicine, so like Norco and Ativan. So whereas for the TNOs or the hybrid procedures and the interstitial, we use anesthesia. So we generally do those procedures under MAC and have the patient most asleep while we're doing the procedure, and then have kind of long-acting medicine while they're getting the imaging. And then we do conscious sedation for the removal.
Any questions? I see the comments, great lecture, super lecture. Maybe a question to Thomas. how expensive are those 3D printers that you are using, and how long did it take you to set up the 3D printing process?
So the printers, the Formlab printers, are about $5,000. So that is considered, rather inexpensive, considering the initial printers that we looked at were about $200,000 for the materials. So these are like a full CT that require all these, facilities help, get the gases in and etc. So these are, simple tabletop printers. They don't require a lot of maintenance. We've had one printer run for 5 years without major problems. And like I said, when you look at the material cost, it's about $10 to $20 per print. So those have been actually really reliable printers. In terms of setting up things, it kind of depends on obviously the equipment component, there's a workflow component, there's a regulatory framework component. Can you work with your sterilization department in order to get things sterilized? That's probably the biggest hurdle that we see here in the US. It's institutional dependent. In Europe, there's a process in order to be able to use medical devices that are not approved. And so I think, Europeans have a system there in terms of, where's the need, let's show the benefit, and then let's roll it out. So it can be a little bit longer depending on the regulatory framework.
Okay, thank you. So I see some questions in the chat. What's your opinion about shielded cylindrical vaginal applicators, I guess? Do you use them?
We don't use any shielded applicators. It's interesting, before we got into some of our 3D printing, or some of our initial forays into 3D printing was looking at shielded components. I think there's several challenges with shielding because the imaging aspect. And I think actually, it seems sort of simpler, to do the hybrid procedures, add interstitial needles as opposed to the shielding.
Plus, you would have to use a more accurate dose calculation, right? Because of the shielding. It complicates things. Okay,
and make sure that the applicator is in correctly during treatment, because a little shift would
make a huge difference.
Yeah.
Oh, that's good. Thank you so much for the great lecture. Do you print a new applicator for each procedure?
So we typically have an applicator for each patient. And so depending if it needs to be recustomized, we'll reprint something for another fraction, but typically these are patient specific, yeah.
One applicator per patient.
Yeah.
Okay. Sounds good. Okay. Sri, do you want to ask a question?
Yes, if I may.
Yeah.
Thank you very much for the great lecture. Actually, it was like very, very, I would say, put it in a perfect order, so it's very understandable. And actually, so GYN is brachytherapy which we use. One of the few in Ukraine that we do use, not interstitial one, but we did have cases when we need to treat both vagina and, for example, cervix. And I know Elekta has some applicator for that, but they don't work very well, actually, to be honest. So the cylinder and the intrauterine tube. So in that case, do you also use, can you use your 3D printed applicator for those cases? And in general, in advanced cases, when sometimes we saw cases when you insert the tandem inside, you're not absolutely sure that you are in a cervical canal. So the tumor is so advanced that it's a little bit of a mess. So what is your opinion about treating with the needles in those cases, if you had such?
Yeah, so when it's tricky to place a tandem because of like the disease and the degree of cervix and or uterus, using the transabdominal ultrasound can help to kind of verify that you're in the appropriate, central canal. very rarely do we have a situation where we don't place a tandem. If there is, a canal, we might add additional needles, to sort of complement, because sometimes that maybe where the tandem is, where the central canal is less optimal. So maybe we'll add needles that will be sort of more optimally positioned. And then in terms of the vaginal component, so I haven't used the Electa one, but oftentimes if there's a vaginal component, we'll add needles, and sometimes we'll do also like the tandem and cylinder. So sort of that via the vaginal individualized applicator, we can also make it so that it accommodates a tandem centrally. So we can have the maybe play, depending on where we're treating or how thick the vaginal disease is, we might place some freehand needles into the vaginal disease with, like transvaginal ultrasound guidance, like if it's, I'm thinking like anteriorly, like periurethral, and then also do the via, which then allows us to treat, the tandem and farther down. But more commonly with the vaginal components, we're adding interstitial needles like into that lower vaginal disease to kind of treat it, or, to have something that goes through it. There's not a lot of great commercial options for vaginal.
Exactly. Yeah. And also, if I can, one more question for Thomas. So you mentioned that the algorithm for brachytherapy is less complicated than for external women. But in principle, do you have like a written procedure for checking or for commissioning TPS for brachytherapy at your center? And also, just as a annual QA, for example, or monthly QA, what type of checks do you do at your hospital?
So there are a number of options out there. First of all, the vendor gives you tests where you can import different points and you know what you expect, because all you do as a physicist, you put in the data from that is the agreed upon data put out by AAPM here of what this source distribution looks like following the TG43 formalism. So there is a check where you put in the data in the treatment planning system, and then you perform, because the calculation is so easy, yourself, for example, in an Excel spreadsheet, and then you compare it, at all types of positions, angles, and obviously the summing also of these. And we do that actually at every source exchange. Every time we change the source, we make sure the dose is that. It's also a way to make sure that the dose activity is correct and also that the TG43 hasn't changed. So that is, effectively what we do. We have a little bit of background noise. I'm trying to talk through it here. So there are guidelines out there by our societies, and there's also guidelines from the vendor, for example, even on how to test your DVHs. So it gives you a volume and tells you what kind of DVH you would expect if you have a source of that type inside. There's a lot of tools out there to be successful.
Thank you very much. Thank you.
Thank you both for a fantastic lecture. Really appreciate your efforts and great teaching. It was amazing also to see good participation and answering questions correctly. So thank you. We will see everyone in not next Tuesday, but Tuesday after, December 2nd. And the next lecture would be brain LDR. Thank you again to our speakers. Have a great Thanksgiving.
Thank you.
Bye-bye.